Well, howdy everyone, and happy August 8th, or 8/8/2018. Those of you who are feeling old by saying the Beijing Olympics were 10 years ago today, that would be me. So I am here with a bunch of colleagues, Margie Amon, Katie Ilton, Catherine London, and Pari Magera, and we are all going to answer your questions. So there's not like a pervading theme. This is just stuff that we either got asked specifically for this webinar or that we've noticed we've been being asked frequently. A handful of announcements. I believe that our topic for next month is going to be a Stark, like intro to Stark, sort of everything you want to know for basic Stark 101. And there's a slim possibility that'll change, but the date on that will be September 12th, same time. As you know, all of these are taped. And so on our website, you can listen to past webinars. We've got, I think, 5 years worth of past webinars there. And so you can listen to those anytime. I think that's it for announcements. If you, when you do the evaluation, if you have a topic you'd like us to cover, we always invite that. All right, let's dive in. Oh, I guess the last one. If the sound is bad, we have a dial-in option. You can look in the chat box. Dan has put the dial-in option there. The most likely reason sound goes bad is internet related and not on our end. So dialing in usually fixes that. So the state of E&M, those of you who read proposed rules first, I apologize for your well-being, but the new physician fee schedule is out and it suggests the possibility of major changes for E&M reimbursement. Now I want to stress the possibility because I have deep skepticism that it will in fact happen. Basically, they did two proposals, and one of them might make sense standing alone, but they went with two. So the two are first for office visits, and this is new and established patient office visits. So the 201s to 205s, 211s to 215s. Medical decision-making will control as your, oh, no, that's actually not accurate. You'll have an option of having medical decision-making control for the level of service. So right now, you can choose the 1995 guidelines or the 1997 guidelines, choosing whichever is most favorable. This would give you a third option. You could get rid of the history and exam components and focus purely on medical decision-making. I'm not too freaked out by that as a concept because it's just an extra option. It's like a bonus feature. So if that's what they wanted to do, fine. What's, in my mind, simply insane, just absolutely beyond any logic, is that they have added a second proposal of making one level of reimbursement for codes 202 to 205 and a second clump for 212 to 215. And you would just get paid a flat rate regardless of the E&M service you provide. Now, you still, under the proposal, you'd have to choose a level of service, but choosing that level of service would have no impact on the reimbursement. Why they make you go to all of that work for something that has no economic impact, I can't fathom that there's a logical answer to, really. I don't think that this will be adopted as is. If so, my faith in government will take another hit. We will know the final fee schedule usually comes out, the earliest usually is Halloween. You know, you kind of hope to have it by Thanksgiving. It's come out as late as December 8th, I remember one year. So sometime around then, we'll know. So it's only a proposed change. They're taking comments through September, and I am now, I should have written down the date. I am forgetting the date. But if you do it by September 1st, you're definitely okay. All right. Declining Medicare patients. Now, this is not Medicare patients who are riding an escalator, nor is it patients who are suddenly unwell, but this is a question from one of our listeners. If you've got a Medicare enrolled physician, they don't want to do something for a Medicare patient because the Medicare reimbursement is too low. So can they say, we'll do this for everyone else, but if you're a Medicare patient, you're out of luck? And I think the answer is yes. I don't know of any reason. Basically, if someone's going to get mad at you here, it's likely to be your medical board claiming you're doing something unethical. Medicare does not require that you do services for people. You can choose to opt in or opt, well, that's a poor word choice. You can opt out of the Medicare program, but being in Medicare doesn't require you to see any Medicare patients. So you could say, no, I'm not going to do this for this person, and that's fine. Similarly, if you don't even need a good reason, really. The best argument someone could make to attack it is that it's discrimination on the basis of age. I think that's a weak argument because Medicare, well, many of the people are above 65. You don't have to be, and not everyone above 65 is on Medicare. So we've generally, I have not seen a successful argument that refusing to take Medicare is age discrimination. I'm sure someone will try to make it someday, but we haven't seen it succeed. All right, now let's do that same question, but with Medicaid. So if you're a Medicaid enrolled physician, can you decline to provide a particular service to a Medicaid recipient because that reimbursement is too low? This is a much harder question to answer because it's state specific. And so this is a confusing thing. Medicaid's a federal program, but everything is state run. And a lot of states are going to have issues with this. Katie's going to answer a question in a little bit more generally, but I'm going to be a lot more nervous about this one. If it's, in particular, most states have anti-discrimination statutes for Medicaid, which means if you're doing something for someone else and you don't for Medicaid, it's potentially problematic. What the penalty is going to vary from state to state. And that's going to be the same then about just you don't want to. Generally speaking, discrimination against Medicaid patients will be problematic. No-shows. So can one department or specialty with a problem of frequent no-shows impose no-show fees? And this came from this question came from someone who already knows that, like there's a no, okay. The no's and the no-shows is confusing me. That already knows you can have a no-show policy that generally Medicare will allow you to say, to impose a fee on a patient who doesn't show up, as long as you impose that fee on everyone, not just Medicare patients, and you give the patient warning about it. So Medicare lets you do this. Medicaid in almost every state will not allow this. So can one department or specialty do it without the others doing it? Sure. I don't know of any reason why you need to have consistency here. I'd say the big thing I worry about is if you don't give sufficient notice, you're going to run into problems both with just irritating people, and you might even have a legal issue, because I think if someone doesn't know ahead of time they're going to get that no-show fee, they would have a pretty good argument that it is inconsistent with the standard of practice out there in the world, and that there's no implied contract that includes a no-show fee. So I would worry about it.
It's sort of interesting that Medicare doesn't say you have to see all of our people, but they do say if there's a no-show fee, everyone has to give a no-show fee.
This is an area where consistency is not everywhere. They will let you have a no-show fee, but they claim to not let you charge interest. And those of you who have heard us talk about interest before, I think you can charge interest using the same argument. The argument that Medicare uses for no-shows is that you can charge patients for lost business opportunity, and that to me would be interest. But kind of weird. Speaking of financial assistance, can different departments or different specialties have different thresholds for financial assistance? And the answer, once again, would seem to be yes. At least I don't know of any reason it would be no. And I don't get very worried about financial assistance. Like, helping the poor is generally not going to get you into trouble. I think the American Hospital Association did us a slight disservice back in like 2000 when they tried to argue that one reason hospitals didn't give discounts to the poor was because they were worried about penalties under the anti-kickback statute. And maybe that was motivating some hospitals, but it certainly shouldn't have been motivating hospitals. Helping the poor, first of all, if someone is not a Medicare or Medicaid recipient, you don't have to worry about the anti-kickback statute. So you can have financial assistance, and those criteria can vary. CMS has asked about possible changes to the Stark Law. What are the changes you feel would be beneficial? We could open this one up. How about getting rid of it? And it's interesting, just as an aside, Pete Stark, the guy who is the name behind, he's Courtney Stark, was a representative from California. He, I want to say 10 years ago or so, said he thought Stark should be repealed. It's worth noting that when Stark first came out, he asserted, when all of us lawyers said, wow, here's a law that prevents doctors from giving a crutch to a patient who has a broken leg, that's stupid, we all said. And he's like, the law doesn't prevent that. And then eventually they realized, in fact, the law did prevent that, and they changed the law. That's only us gray hair people remember that, because that was right at the beginning when Stark 2 came out back in 95-ish. But I think to me, the problem with Stark in one sentence is if you overcompensate a physician by $5, you can wind up with $3 million of liability, and that the penalty is disproportionate to the crime. It's that simple. I think also whenever you have a law that doesn't take into account intent, you're going down I shouldn't say whenever, but often that's unwise. Anyone want to chime in more there? We're just going to move on. Okay, Medicare Advantage refunds. Are providers required to refund and correct claims for Medicare Advantage patients and Medicaid HMO patients, just as they are for Medicare and Medicaid plans? This is a good question. The answer to this is still evolving. We believe that the legal answer is that those private contracts are private contracts and you treat them the same way you would another payer. It is not clear that the government is in agreement on that. There is, I think there's some people who assert that, for example, False Claims Act penalties still apply in those private contracts, but it is quite clear that those contracts can extend benefits and rights that aren't covered by the program. In fact, that's the whole idea of Medicare Advantage, is that the plan covers things that Medicare does not. So I am a fan personally of the kindergarten principle of treat others how you'd want to be treated. If you build wrong, I generally am going to fix that. But if your contract says we only go back 12 months to look at wrong payments on either way, it's completely fair to apply that contractual term. And I would do that and let the chips fall where they may. So that I kind of already answered this one. It was the second part of the question. How are Medicare Advantage refunds and corrected claims handled if the time frame goes back several years? And I think it's a contractual question. And if your contract limits it, you arguably do not need to go back. The same rules regarding refunds and corrected claims for Medicare and Medicaid apply to commercial payers. No, they don't. It's purely contractual. And in a whole bunch of ways, it can maybe be different. I've seen a bunch of one-year contract look-backs lately, and that's not something that Medicare or Medicaid applies. Medicare, I still think, has that 48-month reopening limit, and you shouldn't be going back more than 48 months without carefully thinking about it. The 60-day rule says you should go back 6 years, but that ignores the reopening limit that, say, Medicare can only reopen a claim for 48 months, and if you haven't reopened a claim, it's not an overpayment. Commercial payers, it's purely what's in your contract. The Medicare and Medicaid doesn't apply at all.
The only thing I'd add to that is that your contract will often sneakily incorporate whatever current manual the commercial payer has sitting out on its website. So if you can get that language out of your contract, that's great, but it's hard. So if you're looking for the refund policy or any other policy, you want to make sure you're looking at the documents that are referenced in your contract.
That's an excellent point. And hopefully, for those of you who aren't regular listeners, that's Katie Hilton. If people know voices. But all right, bundled or unbundled? This is kind of a hard one. So receive denials from a third-party auditors when a hospital patient receives a service like a PICC insertion or an A-line or respiratory therapy treatments and stuff. The insurer asserts that they're bundled into the room and board rate. We're stating, we appeal stating they're not routine since every patient doesn't receive them. What steps would you suggest? And, this is tough. You got to, I don't have a magic answer for this other than appeal. It doesn't feel like it's part of the room and board rate. And actually, I think the questioner added that this was being done by like a contracted auditor. So first step, I think people often forget, if you're getting a hard time from an insurance company, don't forget about your insurance commissioner. They will sometimes, not always, but sometimes help. And this to me feels like someone's taking a position that doesn't make a lot of sense. I'd complain to your insurance commissioner. And then you got to use the appeal mechanism that's available to you. And if the insurance company is using an outsider to do this, I'd even complain to the insurance company. And you might think about if you had the leverage, don't contract with that insurance company and let them know it's coming.
Another way to attack this would be to see if there are any regulations that are governing what the auditors are supposed to be looking at. Because oftentimes, well, in the case of the state, they'll engage a contractor to do an audit for their state plan. And the rules that are governing that audit are totally different from how the auditor is acting. So you can actually challenge the auditor's authority, what they're doing based on the law. And that's worked.
Yeah, Katie did that really beautifully once in a situation. Often no one pays attention to their own rules, and they don't know what's in those rules. And so step one is actually just reading them. I think this one has a typo that's my fault. I think the questioner had this one right. But an acquaintance of mine insists an exception has been created under Stark. He says a referring doctor can now own up to 5% of an IDTF and refer his government patients. True or false? Well, with friends like this, you don't need enemies. If there's an exception like this, I've missed it. So I don't know what exception they're getting at. You need to meet a Stark exception. Now, there is something. There is, if less than 5% of a group's revenue comes from Medicare and Medicaid designated health services, and no doctor in the group gets more than 5% of his or her revenue from Medicare and Medicaid DHS services, then there's a start. You basically get a kind of a pass on the in-office ancillary exception, but that's different than this because this is something about an IDTF. I think this is just wrong. This may be one of our most frequently asked questions. We have discovered a bunch of unsigned charts. What do we do? Sign them. I think that's really just date them right? Never lie, right? That's anytime you obfuscate, you get yourself into trouble. So don't pretend that they were signed back in the day, but sign them now with the correct date, and then don't do anything else. I am not refunding money because the chart wasn't signed.
I think a lot of times this question comes because someone has left the organization and they realize that that person didn't sign a bunch of things. And so then it's, how do we make this person come back and sign them? In that case, I wouldn't worry too much about getting that person to, if they will help, great, but I wouldn't lose sleep at night over just not having signed.
And there aren't many things that explicitly require a signature. So for example, people often think orders require a signature, but remember, there is language that says most diagnostic test orders don't even need to be written. I think CMS is unaware that it put that in the Federal Register on October 31st, 1997, but they did. And people forget it, and they have manual language saying orders have to be written, but they don't have to be. They have a written language saying it has to be signed. So I'm totally with Katie on this one. I think this is a thing. Now, you could have a conditions of participation problem, right? That's the biggest. We don't have a magic answer for that one, but a lack of signature for almost any service does not create an overpayment. Can you use standing orders? Yes, you can. And this is pretty clear. And so we stuck the language out of the Federal Register that describes what you need to have for diagnostic tests. They don't even generally need to be written. And there is a bunch of language in, like, for example, the OIG lab compliance plan that talks about how you need to set your standing orders up. But you can have standing orders. There's nothing wrong with them. You just need an order. So what does Michael Cohen teach us about the attorney-client privilege? And I will confess that was not a question someone asked us. That was a question I asked myself. But there were so many bad myths out of kind of the Michael Cohen attorney-client privilege thing. You had Sean Hannity saying, I handed someone $10 to have a privilege. That also appears in Breaking Bad. It's the Breaking Bad theory of what it takes to get privilege. And I enjoyed Breaking Bad, although it's dark. Really dark, but it is a bad place to learn your legal tips. You do not need to pay someone to have a privilege. If you send a question in to us today in the webinar, that's probably privileged, I would say, because you're asking for stuff. You either are a client of ours, or if you're not, you might. You would consider engaging us. We certainly hope you'll consider engaging us, and you don't have to engage us, right? That isn't a condition. If you ask a lawyer a question with the belief that you might engage the lawyer, that's privileged, right? You don't need a formal agreement. Now, does that mean if you buttonhole Margie at a conference, is everything you say to her automatically privileged? Well, no, for a couple of reasons, right? First, if there are other people standing around, that's going to destroy the privilege. And also, if you asked, if you asked Margie about her dog, Bruce, That is not a conversation that's about legal materials. She will happily talk to you about first, but that isn't privileged. If you ask me for a weather forecast, not privileged because it isn't a topic of law. And we're getting more serious about it. You've got a board meeting and you plunk the lawyer down. That doesn't make the board meeting privileged. It only makes legal discussion in there. If you're having a business discussion and the lawyer is merely present, his or her presence doesn't save, or well, I guess save is the wrong word, but doesn't convert privilege where there otherwise isn't one. How do you use modifier 25? So this is a confusing and difficult to use modifier. And I saw a consultant recently who came to one of our clients and said, unless the service is separate, identifiable, and unrelated, you can't bill for a procedure. So this is the modifier that's used when you bill a procedure that's done on the same day as an evaluation and management service. So a classic example, you come in for your physical and you're getting your colonoscopy done the same day. Or also really common with injections for chemotherapy, things like that. So the consultant was saying that it has to be separate and identifiable and unrelated. There's a giant problem there. Separate and identifiable is correct. Related is unrelated is the consultant's own personal interjection. Or in this case, injection. We were talking about these were eye procedures. And the question was, if the patient got an injection that day under the consultant's view, the injection had to be unrelated to what happened in the encounter. That's inaccurate. Now, I see all kinds of consultants who are really tough and all kinds of contractors that are auditing on modifier 25. The real test is the office visit when it's happening something that you wouldn't automatically do because it is part of the procedure. So if you at a visit say, come in a month for this injection, and you know you're doing the injection in a month, and you ask the person when they show up, how are you doing? That's probably bundled in. If you need to evaluate in a month whether the person really needs the injection or not, you're trying to see something, that's where the E&M service might be independent and billable. It can be tough on that. Chemo, it's hard to know in there whether you need a separate visit or not. In this particular case, there was actually discussion that the RVUs for the procedure didn't include any conversation with the patient, which made the particular one we were looking at simple and the consultant who we were working with wrong. We billed under the wrong doctor. Are we toast? No. And I mentioned this because I just had a client call. They had refunded $275,000 because a big East Coast law firm said, you billed under the wrong doctor, you've got a refund. It came up as part of a transaction. Bad advice. You don't need to refund. They didn't need to refund. We have now appealed from their voluntary refund. And guess what? You can appeal from a voluntary refund. That's clear. It's most clear if you do it on particular claims. If you do it on a random sample, that's a lot less clear. Okay, I want to cover a couple quickly to leave time for some of these other ones. Actually, I put this question in, and I am going to just skip this one. It's not that interesting. This one's more important. Should I do self-audits during an outside audit? My answer on this has flipped over time. I now say if you're dealing with Medicare, no. If you're dealing with Medicaid or another payer, I might. Actually, Medicaid, I probably would say no to. If you're dealing with a private payer, I think I would start. So what's the difference? Under the 60-day rule, if you do a review and your reviewer concludes you've got a problem, the claim is overpaid, you're going to have to return that money. And in our experience, the odds that your reviewer and that the government's reviewer will disagree on whether things are at issue is too high. I would rather wait for you to get the government's reviews and then you focus only on the ones they find fault with. The negative of this is it gives you less time, right? You're going to have to work faster. So the answer is get your consultant all lined up and ready to go. But I would not do a parallel review while they're doing theirs, and it's totally because of the 60-day rule. Okay, what about BPCI Advanced? I'm going to turn to Margie to comment on this a little too, because she and I have been up to our eyeballs on this. We won't spend long on this, because if you're not signed up, you can't get into this program until 2020. But this is a program that allows for certain codes, primarily orthopedic and cardiac and the like. You can participate on a risk basis to get additional payment from CMS if you meet various criteria. You had to have signed up already, which is why we're not going to spend a lot of time in, because if you're in, you kind of know what you're doing already, although I've spent enough time in the last couple weeks. Even CMS, as of last night, is sending out Q&As that I think completely change what we thought the answers to a variety of questions were. I find this to be alarming.
Yep.
I don't understand what's going on.
I think that's fair, David. Yeah, there's a lot of new information coming out. Seems like CMS is kind of rapidly trying to interpret the agreement that they put out themselves. So there's a lot of details to still be sorted out, but there is a deadline of today for conveners and participants to be submitting their participant profiles. You might be hearing a lot of activity around today as a deadline if you are participating as an administrator or participant.
So one of the most controversial issues involves a 50% cap. What's got everyone so worked up about the 50% cap?
So the 50% cap is an idea that existed in some form in the original iteration of the BPCI program, but in the second iteration, they are applying it at 2 different levels. So this would be on the payment that comes from CMS to be distributed downward, and the 50% cap as applies in this iteration of program would apply at both the level given to the NIPRA sharing partner, as they are calling it, as well as the individual practitioner.
All right, thanks. And that is, I think the interpretation of that, and the way CMS is handling it is one of the most confusing things in here. I read their Q&A last night and I don't understand it. I think it's internally inconsistent. So can I accept outside referrals on a scanner? Generally, the answer to that is yes, as long as any financial relationship that you have with whoever is referring meets the Stark exception. If you're in Florida, you have to know about a state law that limits the percentage of outside referrals to 15%. And then I remember Katie Hilton and I first worked on this when you were a young lawyer, the IDTF myth, which was the idea that if a majority of your majority of your income came from referrals, that was a problem. But A, that language is gone, and B, that was only really in IDTFs because you never have a majority of your income in a practice come from outside referrals. So you can accept outside referrals. This isn't a common question. This is one that we wish was a common question. Do you have to give patients a notice for imaging? If you do MR, CT, and PET, and you're a physician-owned practice, I hope you are saying to patients at the time you suggest that they get a scan that they can go someplace else and give them at least 5 suppliers, if there are any, within 25 miles that do it. It's only suppliers, not providers. The difference, a supplier is like a physician practice or an independent diagnostic testing facility, things paid under Part B. Hospitals are providers. You don't have to talk about them. All right. I am going to turn this over to Ms. Hilton.
Can I have a hospital with just 1 bed? So this is an interesting issue that we've seen come up from several hospital clients, and that we also are seeing some recent enforcement on. And it's enforcement of a statute that has been on the books for a long time, but that CMS is interested in now. This is about whether you can be a hospital with just 1 or 2 beds and focus really on other things, maybe like emergency services or outpatient services. So the inpatient gig isn't really going well for whatever reason, and you want to focus on all these other services that are better for all these reasons. Well, what's happened is that CMS is looking at the statutory definition of hospital, which says a hospital is something that's primarily engaged in providing inpatient services. And just about a year ago, CMS released some guidance to its surveyors to say, look, surveyors, we really want to make sure that hospitals are out there being traditional hospitals with respect to inpatients. And we aren't loving these hospitals that are sort of being just ED centers or just outpatient centers. And I can send you a link to this guidance. The surveyors are looking at things like what's your average length of stay and what's your average daily census. And it seems that 2 is the magic number. They're going to look at whether over the past 12 months you've had an average length of stay of 2 or more days and whether you've had at least 2 people in the hospital. And if you haven't, then you run into an issue with CMS wanting to terminate your provider agreement. And that actually happened to a hospital just recently that was looking at basically being a surgical hospital and keeping people in the hospital for less than 2 days. And they surveyors came along and terminated the provider agreement, which was just bad news. That hospital is challenging this action in a federal court case, so we'll keep you apprised of that. But be aware of when your business development folks are thinking about hospitals in a new way, that you're thinking about whether it continues to meet the definition of a hospital that CMS thinks it should. Now, I would note that this primarily engaged standard does not apply to long-term care hospitals or to critical access hospitals. So those folks have different struggles and issues, and this is not one of them. This is a question we get pretty often, and sometimes it's sort of mentioned as a solution in the course of a discussion on something else, but we have to remind clients, can you bill incident 2 in the hospital? So incident 2 billing is the situation where you have one practitioner who begins a course of treatment, and then auxiliary personnel, whether that be other practitioners or nurses or medical aides, provide services in that course. And even though the physician maybe who originally started the treatment isn't the one doing the services, they are supervised by a physician, and as a result, the clinic gets to bill for the physician rate, not the rate of the folks who are the lower rate, the folks who are providing the service. So this is obviously attractive from a financial standpoint. The really important basic fact to remember is that incident 2 billing that I just described is only allowed for clinics, not in the hospital. And that includes not in the hospital outpatient department. So, for example, if you have psychotherapy or any service going on in the hospital outpatient department, and you're planning to use auxiliary personnel, but still bill incident to a higher level provider, then you need to watch out, because in the hospital that just is not permitted. David chatted briefly about this. Can the clinic stop seeing Medicaid patients? This depends on state law. The only other thing I would say is that if your state law doesn't say anything about declining Medicaid patients, it may still say something about the effect of that. If you decline Medicaid patients, some states say, then those folks can also not participate and see patients in other state healthcare programs. And so it can have a domino effect that isn't necessarily obvious when you're looking at the statute. Do we have to let someone in who wants to take pictures of our DME posts or prosthetics? What if someone comes to our office and they want to take pictures of our inventory? That sounds very strange and odd. But in fact, that has happened to several of our clients and several DME post suppliers out there. And you know, instinctively, the folks at the front desk have said, no, you may not take pictures of our inventory in our back office, or and turned the person away. But I think in all cases that I've heard these requests come up, it has in fact been a revalidation representative from the DME post contractor.
I mean, there aren't a fleet of people walking around trying to take pictures of people's prosthetic products.
It's a strange request, but in fact, there are some not very well labeled contractor representatives who are trying to do revalidation surveys. And most of you probably know that CMS is really sticklers with respect to DME suppliers. They want to see that you have inventory. If you don't, they think that you're fake, and you should get your supplier number revoked. They also want to see that you are there when your hours of operation are posted. And this is very, very tricky. You have to be very specific. PARI and I just dealt with one where the hours were posted pretty clearly, but there was some variation that was allowed for in the posted hours. And even just a range of hours is not sufficient. You have to state the exact hours you will be there. Even if your site is closed for construction, and that might be very obvious, if your hours, as reported to CMS and as posted, say you're open, you have to be there, even in the middle of a construction site. And there's not much respite from these appeals. The judge will enforce them to the T.
Hey, Kate, so from a practical standpoint, what do you tell a receptionist? I mean, if someone shows up wanting to do something, do you have any advice for how you train receptionists to deal with this
conundrum?
Well,
you know, the thing that you always want to ask people when they come knocking is, can I have a picture? Can I have your business card? Can I try to look you up online? Can I try to figure out who you are to see if they are who they say they are? And so that's really going to be helpful in making sure that the person is legit. So this is another common question we get. Do you have to bill the site of service consistently with all payers? There's no law out there that says you have to use the same site of service for all payers. And in fact, payers have different rules about sites of service. Oftentimes, Medicare specifically has rules about sites of service, and they recognize provider-based billing, so you're going to be billing outpatient in situations where for a commercial payer, you might be billing clinic because they don't recognize outpatient versus clinic. So you need to be paying attention to what the particular payer requires. Do I have to use the OIG disclosure protocol to refund an overpayment? In fact, no, you do not, and I still have not run into a situation in my career where I recommended using the OIG disclosure protocol. It's a voluntary protocol. It brings a lot of attention to the matter, and David may have a circumstance where he's recommended using it before, but it's few and far between, and really the requirement is the law, the report and return law, which says the money should actually go to the most appropriate entity, and to us, it's the contractor that paid it. And our experience refunding to the contractor is that very, very few times have we seen the contractor come back and ask questions.
Yeah, I think it really is a situation. I mean, it has happened to me, but it's pretty rare. It is not the preferred way to go. All right, I'm going to turn it over to Catherine London. We're going to talk about cell phone recording your medical visit.
So one question that comes up from time to time is whether patients can use their cell phones to record their medical visits, and specifically when the healthcare professional is not actually aware the recording is taking place. The answer to this is it depends on state law. It's governed by federal and state wiretap statutes, interestingly enough. And under federal law, phone calls and conversations can actually be recorded if at least one of the parties to the conversation provides consent. And most states have similar one-party consent statutes allowing people to record conversations to which they're a party without informing the other parties. However, there are still, I think, around a dozen states that actually do require the consent of every party to the conversation. So in those states, a patient actually can't record an office visit without the express consent of the professional. And a couple other quick points on this. You know, HIPAA doesn't prevent this type of recording since it's the patient's information. However, there could be some issues if the recording might be done in common areas or if there's some other risk of capturing other patient information. And on a malpractice front, you know, typically the purpose of these recordings, most patients just want to capture information to share with caregivers or so that they have them available for later on. But I have heard of a couple cases in which patients have tried to use recordings as evidence to support malpractice cases. So, I mean, it's not entirely without risk. And some providers will have cell phone policies or notices posted about leaving cell phones outside of the office or asking before beginning a recording. But ultimately, this is something that'll happen more often on account of our modern age. Next, can we offer free transportation to patients? And the laws that are most relevant to this question are the federal anti-kickback statute and the civil monetary penalties prohibition, as well as the state law analogs, because the main issue is whether the intent of offering the free or, in some cases, reduced transportation is to influence referral or patient selection of a provider. And the OIG in the past issued a few advisory opinions approving transportation or complementary transportation programs in some circumstances. So we previously told clients, what the OIG considered to be the primary risk factors that were relevant in analyzing arrangements, and also advised that transportation should be, from site to site and not from a patient's home. However, in January of last year, OIG actually finalized a new safe harbor, the anti-kickback statute, as well as an exception to the CMP prohibition. And so under these new exceptions and safe harbors, they protect free or reduced transportation by an eligible entity provided to a beneficiary if certain criteria are met. And we've put the criteria on the next few slides. I won't go through them in depth, but notably, it has to be locally, so within 25 miles of the provider or supplier, or 50 miles if it's a rural area. And also the exceptions allow for local shuttle services to be provided to patients under certain circumstances if they meet the requirements. And also, again, this must be local, so the shuttle can't run more than 25 miles between any particular stop and a location where healthcare services are provided. Again, up to 50 miles in rural areas.
I'll just chime in to say,
Sure.
I've never been super, like, there are sort of different kinds of transportation, and transportation to and from a patient's home comes with some peril. There's another shift, I think, which is moving people from one facility in the health system to another, and that has caused us historically not much risk. So for example, if you are, well, I'm going to use the Twin Cities. We got St. Paul and Minneapolis. Patient, lives on the east side of the city. They drive to St. Paul, but you've got something in Minneapolis. You want to move them from St. Paul to Minneapolis. Can you, the provider, do that? I think none of us worry about that.
Right.
It's really to and from home that has questions, not from hospital A to hospital B.
Next question, can we release medical records we received from a third party? And the answer to this is most generally going to be yes. Under HIPAA, PHI is considered any health information that's created, received, or maintained by a covered entity. So in other words, PHI is not just what a provider creates as part of its care of a patient, but includes information it receives from either the individual, another provider, or another third party. And under HIPAA, a patient has right to access or authorize release of any records the covered entity maintains in a designated record set. And that's regardless of whether the covered entity created those records or not. Note there are some exceptions. So the records of a Part 2 drug or alcohol abuse treatment provider cannot be redisclosed without the express consent of the patient. So that's one instance in which there's a kind of clear exception to this general yes, disclose them. And there are some other restrictions with respect to psychotherapy notes as well. But in general, yes, you can and also must release records created from or collected from other providers unless one of these exceptions applies. And I must add the kind of caveat that you have to remember state law could come into play and affect the analysis. I'm going to pass it off to Margie Ahmed now.
All right, so keeping along the HIPAA subject matter, but starting with a very easy question is, do I need to do a security risk analysis? And the answer there is a clear yes. If you are a covered entity or a business associate, you need to be performing a security rule risk analyses under the security rule of HIPAA. So the question is not whether you need to do it, but it's a matter of how comprehensive that risk analysis needs to be, and then your implementation after the fact. So a risk analysis is a comprehensive evaluation of your entire enterprise in order to identify all of the electronic PHI you have, and then also the risks and vulnerabilities to that electronic PHI. In April of 2018, OCR put out a nice little guidance document about the difference between a risk analysis and a gap analysis, which just highlights how thorough and comprehensive your actual risk analysis has to be, and that performing a gap analysis, while it might be advantageous to your business, is not enough to comply with HIPAA. So that's available on the OCR website, and it's a good idea to take a look at that. You should also be identifying clear items to address in your risk analysis. Some kind of key topics include ransomware, encryption, software patches. OCR also recently put out some guidance on software vulnerabilities and patching in June of this year. And then we have a very recent ALJ decision for the University of Texas MD Anderson Cancer Center, which was just recently announced by OCR. And that was a situation where the Cancer Center had the very common culprits of an unencrypted laptop and unencrypted USB drives that were lost that resulted in a breach. The problem is that they had identified these as high-risk areas in their risk analysis and failed to implement safeguards to prevent that kind of high risk within a reasonable period of time after the risk analysis.
So Margie and Katie, speaking of $4.3 million, is it going to cost $4.3 million to do a security risk analysis? Is this like a major project that you would have to do? This is the stuff you guys do. We're out of my wheelhouse here.
Well, $4.3 million seems a little steep for risk analysis. No, it won't. It shouldn't be a staggering amount. And the way we like to do these is to actually have the client do most of the work. Maybe that's because we're lazy, but I like to say, and I do think it's because this is a tool and not just a one-time snapshot. And in order for a tool to be effective, you need to be able to know how to use it. And so we like to work with the client and their IT partner, whether that's in-house or external, to create something that is a living, breathing document that they can go off and use without us for the future. So I've seen a lot of quotes for risk assessments with really like tens of thousands of dollars type of price tag, and it's just not been, that hasn't matched up with the risk analyses that I see that are effective in preventing issues.
So you can hire a consultant to do it for $30,000. You might be able to work with the legal counsel for
That's right.
a substantial, smaller portion.
Yes.
All right, the next question, do you have to report a ransomware attack? So I'm just going to touch briefly on this because we've covered ransomware numerous times before on other webinars that are posted on the Fredrikson website. And OCR issued some substantial guidance on ransomware back in 2016. In that, they said it's probably not a matter of if a ransomware attack is going to happen, but it's a matter of when. And so you should be prepared for ransomware, like I just talked about before. It should be something that you're looking at for your risk analysis, and you should have kind of everything in your power in place to be safeguarding against ransomware, including contingency plans and training your workforce. But in the event it does happen, you're going to do a breach analysis very similar to what you would do in the event of any other potential breach of unsecured PHI. You're going to look to see whether the PHI was actually unsecured, and you're going to look to see if there's a low probability that the information has been compromised. OCR announced 2 additional factors that you need to consider when it's ransomware. The first is whether there's a high risk of unavailability of the data, and that goes to the nature of a ransomware attack because it prevents you from actually having access to that information, and then whether there's a high risk to the integrity of the data. So very similar, but you're going to take a slightly different approach when the breach is ransomware related. The next question that we get fairly frequently is, can we send emails to patients? And the short answer is yes. There's no law that prevents you from sending emails to patients, but there are a bunch of recommended precautions that you take. Specifically, if there's going to be PHI in the emails that you're sending, and given that you're communicating with patients, it's highly likely that there will be some aspect of that email that is considered PHI. OCR has some guidance on this that they have issued, and their recommendation is that you, prior to sending any sort of email to patients that includes PHI, you should either first and foremost send it by an encrypted email if that is possible. If the patient has requested that you send that PHI via unencrypted email, OCR puts the onus on the covered entity to explain the risk of sending that information via unencrypted email, and you have to get the patient to consent to those risks prior to sending it. You then also need to make sure that you do your everything on your end to make sure that you are sending it to the right email address. We often recommend that you first send a test email to confirm the email address before actually sending any sort of PHI across to the patient. All right, another topic is whether or not $6.50 is the new maximum charge for copies of PHI. So there's been quite a bit of confusion around permissible charges for copies of PHI. That goes back to some clarifications that OCR put out regarding the right of access. The patient has a right of access to their PHI, and when the patient requests PHI, a covered entity is restricted in how much they can charge. OCR put out some guidance that outlined 3 different methods for calculating the amount that can be charged to a patient. The first is actual cost, the second is average cost, and then there is this flat fee of $6.50. And that one relates to electronic PHI, and that's based on their calculation of how much it would cost to put electronic PHI on a portable disk and send it across to the patient. So no, the short answer here is that $6.50 is not the maximum charge. You can use any of these 3 methods, but you should be clear and upfront in the methods that you are using and make sure that you notify individuals in advance about the approximate fee for those copies. And now I'm going to turn it back over to David.
And I am going to skip 10 slides because we've got 10 slides that deal with pricing. And I think what we'll do is in one of the upcoming months, possibly October, maybe even yet September, we will do a whole webinar on pricing and fee setting and the like. So we're going to skip ahead and just go right through all of our pricing stuff and get to a few questions here, and then we've received yet more today, so we'll end with those after. I've got to turn it over to Pari. So I get legal advice. Can I share it with others? And I think people often don't understand that if you've got a letter from your lawyer and you hand it to someone else, that's often going to waive the privilege. There will be an exception. So if you have a common interest, and so an example might be a hospital and a physician group are thinking about entering into some sort of financial relationship, right? And it might be a Stark problem. They have a common interest, and they're getting, if either of those 2 parties got a legal opinion, I think sharing it with the other party is probably that should pass muster. And you'd say they have common interests, and that should be protected. And actually, if it says it's okay, it probably isn't that big a deal if the advice gets discovered anyway. But don't share letters or emails you get from your lawyer with someone else and who's outside the organization. Within the organization, those that have a need to know you can share, that's fine. But if you share outside the organization, that is often going to destroy the privilege. And the only argument really you'll have is that common interest argument. Can doctors get credit for ordering ancillaries? So under Stark, the answer is no if it's a DHS under Medicare. It's unclear if it's a DHS under Medicaid. There are courts that have ruled yes. You have to know what your state law is. A bunch of states expand Stark. California, Florida, New Jersey, New York are amongst those. Us Midwestern states generally do not. So you can divide the money however you want as long as it isn't based on who ordered it. It can be equally. It can be production. Just don't do it based on who ordered it. How often do I have to check the OIG exclusion list? So there isn't a law that does that. What there is CMS policy. And actually, there's a SNF exception. SNFs are actually, as part of the Affordable Care Act, require skilled nursing facilities do have to check the list. But the government right now seems to think that you're supposed to check it like monthly or bi-monthly. I think that's insane. Personally, I would do it twice a year, or at most, or once a year. But they have given us guidance that they want people to be checking monthly.
And you'll probably see this being pushed down by your Medicare Advantage plans and your addenda that you have to sign that say you're doing all these things right, including checking the list all the time.
And that leads us perfectly into the next slide, which is, do we need to do the fraud, waste, and abuse training that these Medicare Advantage plans want us to do? And it is important to remember that the regulations do not apply to you unless you are a Medicare Advantage plan. I don't think we have any on today. You are not required to do it legally. It's only required of you if you sign a contract. So the plans are sort of required to foist some stuff on you. You don't have to agree to things. It all comes down to what you agree to in your contract with the plan. The more leverage you have, the more ability you have. The requirements are waka waka. So they're like, it could be read as requiring you to make everyone watch this 70-page boring slide presentation stuff. This one's more for the physician groups out there, but I suppose it could apply to a big hospital too. Can we make a shareholder or employee reimburse us for damages? And the answer is very state law dependent. Many, but not all states, have a state law that says if the employee acts in good faith, thinks they're acting in the best interest of the corporation, and thinks that their actions are legal, often the company is required to indemnify the employee. That's not universally true. It's a state law question. If you want to make changes to this, A, you'll want to generally do that in your corporate organization documents, and B, you'll want to make it pretty clear and overt up front. Those principles aren't to me necessarily bad. I like those, right? I don't want to make an employee reimburse you if they are acting in good faith and think what they were doing is legal. And in fact, having employees know this will, like your coders who are all super scared that they're going to jail, tell them this, that if they're acting in good faith, they're not going to get in big trouble. The company stands behind them. That's useful things for them to know. By contrast, if one of your doctors is ignoring your E&M reviews, and we haven't gone to the new system that pays a flat rate, saying to them, if we get in trouble because you won't listen to us, you owe us the money, that seems totally reasonable to me. Okay, so I'm going to turn this over to Pari, who's going to whip through a few questions, and then we will go through the new ones that have come in since we did our slide.
Okay, so we get with some frequency from providers and professionals an email that says, I've gotten a subpoena for medical records. Do I have to respond to this? So I think sort of as a baseline, generally subpoenas require some response. So the first sort of step is to figure out what is the right response. You want to look at whether service is proper. So was this directed to the correct person? If state law requires it or the appropriate administrative or court rules require it, was it personally served or was it via mail? If it's coming from out of state, there might be certain rules that it has to go through a local court first and get what they call domesticated. So you or your lawyer can make objections based on improper service. If it wasn't done correctly, that tends to be a delay tactic rather than a get out of the problem entirely tactic. But in some cases, it turns out the person who's requesting it doesn't care enough to correct the service. So that ends up being a one-time sort of quick letter that you can sort of send out. Assuming service is proper or you've decided you don't care about that, you should consider whether there's an authorization enclosed. So often a subpoena for medical records, particularly if the subpoena is issued by counsel for the person whose medical records they are or in a dispute involving that person, often there'll be an authorization right in the envelope, so then you don't have an authorization issue. Another question is whether the provider already has an authorization on file. I recently spoke to exasperated opposing counsel who was insisting that we actually had an authorization on file because why would they be subpoenaing us if they didn't know we already had it? So you can save yourself some trouble if you feel so inclined to save yourself the trouble of checking to see if you already have the document on file and it's just not in the envelope. You can fight about it if you want to, but that's sort of a lot of rigmarole if in fact you actually have the document. The next sort of question is whether the HIPAA requirements are met if there is no authorization. So that would be, is it signed by a judge? So some subpoenas, administrative subpoenas, might be signed by an administrative law judge, in which case you're not so worried about authorization. If it's signed by a lawyer, HIPAA or court clerk, HIPAA requires satisfactory written assurances, which is a technical term under the regulation. That means that they've tried to contact the person whose medical records they are, and given that person an opportunity to object, et cetera. And then sort of the last issue is whether state law might be more restrictive than that. Remember that HIPAA is a set of rules where if state law is more protective of individuals' privacy, it gets trumped. So in Minnesota, we typically take the position that even a HIPAA compliant subpoena is not specific authorization in law as required by the Minnesota Medical Records or Health Records Act. So. Can you help me understand which button it is, Catherine? Forgive me. Okay. Perhaps I'm out of batteries on the clicker. The next question is one we received from a client. If we're not a contracted provider for an out-of-state Medicaid plan, can we bill the patient? I think this is a state law question. Sometimes a state will have a statute or a regulation that says that you have to accept payment as payment in full. It's not, if you're talking about a sort of fee-for-service Medicaid plan, then I think that's more likely to be true. If you're talking about an MCO, Medicaid Managed Care kind of situation, that's less likely to be true, but there still might be state law that prevents you. There also might be state-specific, more sort of general prohibitions on balance billing, which you may or may not be familiar with just from dealing with out-of-network patients in the general sense of things. And then assuming that there's no state law kind of issue, I was also going to mention fee schedules. So some states might have a statute that says accepting payment from the state requires adherence to the fee schedules, and you can't bill beyond that. We've seen that specifically not in Medicaid, but in workers' comp for sure. Assuming there's not a state law barrier, then you're sort of in your general no man's land of out of network. And David, unfortunately, skipped all of his slides on that, so I can't just punt back to David's discussion.
We're doing it. We'll do it enough.
Right.
Stay tuned.
Right. Stay tuned for the dangers of the many pitfalls associated with dealing with out of network patients and sort of coming to creative billing arrangements there. All right. And then my last little grab bag of a question is, can healthcare professionals sell goods directly to patients? Not surprisingly, based on sort of where we've been so far, this is a state law question. Might depend on the practitioner type, since these kinds of issues are often dealt with in board rules. So a chiropractor might have a different rule than a dentist might have a different rule than a physician, for example. Some states might have an outright prohibition. You may not sell goods to your patients. Others might have sort of more ethical general principles, in which case the board might, if they are worried about this for whatever reason or receive a complaint, which I think how it would come to the board's attention, the board might take a more general ethical principle, which would be probably in the board regulations, like you have to conduct your practice in an ethical manner, you must avoid conflict of interest, or some sort of general catch-all kind of requirement and try to shoehorn that kind of an issue there. Some states and some practitioner types have specific disclosure requirements. So you would tell your patient that you have an interest in dealing with or in receiving payment for these kinds of goods and let them know what your interest is. If you're worried about a more ethical or general ethical catch-all, you might try disclosing anyway, because you're more likely to be seen as ethical if you're totally open with your patient. All right, I think that we're ready to move on to our questions that we've gotten from people listening today.
Right. Mr. Party, we have a number of little grab bag questions here. The first one, are hospitals' medical record numbers or laboratory case numbers considered PHI? The government defines PHI as any unique identifying number, but then the regulation says PHI is something that identifies the individual and with respect to which there's a reasonable basis to believe the information could identify the individual. So this is a really good question. I think what's happening here is that there's a set of things that are, if you strip them away from a document, then they are categorically de-identified. And one of those things that you have to remove is a unique identifying number or a medical record number. So if you remove all of those things, then you have something that is not PHI. But let's say you just have a document that has the medical record number or a list of medical record numbers disclosed. Does that mean that you have a HIPAA violation? PHI is actually more broadly defined as something that either does identify the person or reasonably could be used to identify the person. So I would say that you can't call what was disclosed de-identified and not PHI because it does have one of those things on it. However, if someone was looking at it, they would not reasonably be able to tell who the patient is based solely on their medical record number. So I think you are not toast if a list of medical...
It's not de-identified, but not a breach.
It's not de-identified, but it's not an improper disclosure.
This is why I'm glad I have you guys. I would not.
So, and then I will say my unsolicited advice is to try not to use medical record numbers when you're identifying a list for outside coders or something. Just use a totally neutral, different set of a different list that you can't trace back to the hospital. I think that's the best case scenario. But if you, let's say someone emails out a list of medical record numbers and that's it, it's not a breach.
Okay. So does the 60-day rule apply to Medicaid patients as well? Statutorily, yes. Regulatorily, the regulation that came out only applies to Medicare, only Title 18, but the law applies to both. I've got some more here. Katie, do you have more?
This is a good one. If a mid-level provider is not credentialed with a payer, but the supervising physician is it okay to bill for the services under the physician's name? It depends. Medicare in the office will let you bill Incident 2 under the supervising physician, provided that you meet all those other parts of Incident 2. It has to be in the same course of treatment. The supervising physician has to have provided the requisite level, and they have to be in the office suite, and those are met. But if those are met, then you have an opportunity to bill Medicare. Most other plans that I know don't do Incident 2 billing. So don't assume that just because Medicare does Incident 2 billing, anyone else does. In fact, I think most people probably don't. And with respect to commercial plans, typically we see commercial payers being really specific about wanting to credential anyone who's touching the service or patient and not paying extra or separately for supervising work. Oh, and one more thing. Medicare, people often say, well, the rule is that if Medicare does it, then Medicaid does it. In fact, they're separate, and you have to look at that question.
So a couple of smart listeners, and we always preserve the anonymity of our listeners, so I kind of want to credit them because they've just schooled me on something, is that CMS removed the rule requiring MA plans to require compliance training for downstream entities effective in June of 2018, which totally slipped by me. And the site as provided by this kind individual lawyer who I know and like is 83 Federal Register 17440. I'm going to trust that she's right because she's smart. So I think I just got schooled in something. So that's one. Can you provide the link to the verbal orders? And I think that's probably the discussion about oral orders. And there's not, so here's one piece on which I rely. It's the Federal Register from October 31st, I'm totally blanking, 1997. And it was the Medicare physician fee schedule when it came out. And it was, that rule was actually talking about independent diagnostic testing facilities, and it said we're requiring written orders in an IDTF. But everyone knows we don't require written orders in other situations because IDTFs are bastions of fraud and no one else is. So it's sort of an inverse, it's overtly stating generally you don't need a written order, but in an IDTF you do, and then it sort of all kind of follows logically from there. There is manual language that completely contradicts that Federal Register stuff, right? You have to know that. It's just that I think that they've forgotten that that's in the Federal Register. I've got, do you have any more? I've got a couple.
So the same one that you just answered.
Under the Stark safe harbor for restocking ambulance medications, it's appropriate for a hospital to restock ambulance medications that are expired. Or is it, sorry, let's try that again. Is it appropriate to restock medications that are expired in addition to those that are used during the transport? Now, I wouldn't sell myself as a top expert on the restocking safe harbor, but let's just analyze it in a couple of ways. So first, remember, you don't have to meet everything that's in a safe harbor. Safe harbor set up sort of principles. A lot of this is intent-based. And so the question becomes, why are you doing it, right? If you're doing it because this ambulance is driving around with expired stuff and you better get something in there, and so you're going to put a couple of vials in case someone runs into trouble, that's clearly okay, I think. If you are saying, we're just going to help every ambulance that comes in here by becoming their stocking company so that they will use us, then you have an intent question. So this is going to be intent-driven, and if you're fixing one expired vial, you notice, I wouldn't be worried about that in the slightest. I think, let's see. Are coders personally liable for what? Wrong codes? Well, coders think that they're personally liable all the time. And as we talked about in indemnification, they generally are not. But the fact that they are is something that often causes them to go to the government. So allaying their concerns, if you can do so, is wonderful. And I see, I don't know if do we have one more?
One more quick one for the slide. This person's saying for this slide that talks about providing patients with information on outside providers for MRI, CT, and PETs. What's the legal authority for this? Where can I learn more? Happy to send you the legal authority. It is part of the Stark law and specifically the in-office ancillary services exception regulation.
All right. So in September, I don't know, maybe we will do pricing. We'll figure out if we're going to do pricing or Stark. Probably one's September, one's October. We hope you'll fill out the evaluations. You can see our contact stuff on there. You can always reach out to one of the 5 of us, or for that matter, anyone else in our group anytime with questions. Thanks for dialing in.